Arsham. For those who don't know, for the audience here, I'm sorry, you're going to hear it one more time. Arsham Shabani is coming to us from Washington University in St. Louis, where he is both the residency program director and the glaucoma fellowship director. So he's a very busy guy. He did his medical school and residency in Washington University in St. Louis prior to coming up to Toronto for fellowship with IGOMED in glaucoma and an advanced anterior segment. After that, he was recruited back to Washington University, where he is now. In addition to everything else that he does, he's just one of the smartest minds in medicine, smartest minds in ophthalmology. If you ever ask him a question, you will get a very insightful response because he's already thought about it. Right? So there's very few people in medicine who are like this, where you ask them a question and they don't just give you a token answer, but they will give you a very well thought out answer, but fairly immediately. And I think that's quite impressive. I did mention earlier, but one of the interesting things about Arsham is when he was in medical school, he wanted to be an OBGYN. And he chose against that because he didn't like the labor and delivery aspect of it. And so naturally, he became a glaucoma surgeon. And I think there's some sort of aversion that this guy has to dilation in general. But it's a pleasure to have Arsham here in person and lecturing for VPP and then resident teaching afterwards. We appreciate the effort you're making to be with us today, Arsham. Thank you.
Thank you so much. All right. So, a couple of things. The OBG part, it was really gyn-onc that attracted me. I think glaucoma is kind of like that. I tell patients it's a cancer that doesn't kill you, but it's really bad disease, and it's generally true medicine, right? We have surgical, preventative, medical, and a lot of it is a psychiatric component as you take them through the disease. I do want to say a couple of words. Had just the fondest memories of Toronto, especially being with Ike. I don't know if there is a better person who has been involved in my career, even though he really has not had to be. Hundreds of miles away from him at a totally different university, and he has been probably the biggest supporter. I go into education thinking about him on a daily basis, and like Amandeep said, program director. So what we're going to do today is a little bit of a more Socratic method of going through the talk. It's not going to be embarrassing. This is not something that you need to worry about being put on the spot. I do currently work with some of the companies that are involved in the MIGS and glaucoma space. Let me see if we can. Yeah. Okay. Yeah. All right. There we go. So a little bit about UBM. So I have listed right here, it's 25 to 50 megahertz. What is phaco? You guys know the frequency of phaco? Guesses? What's that? Depends on the machine, but just a range. Yeah, so in the kilohertz range. So 25 to like 60. And your ear detects less than 25 kilohertz. So this is a much order of magnitude different range as far as what these scanners look at. The resolution is great. And there are some research scanners that have very close to OCT-like resolution. OCT is really going to win out, though, as far as resolution goes, but it's the tissue penetration that is pretty critical here. And you can get through things that are optically opaque. So the axial resolution, when you're looking at, the depth, it's about 25 microns. So tissue planes that are 25 microns different, you can distinguish those. And then the lateral resolution, so the side to side, is about 50 microns. So still really good. OCT, though, you're talking some research scanners can get up to like 4 to 6 microns. Like your conventional stuff's going to be about 10 microns on OCT. But it's that depth of penetration that matters. So I'm going to show you this video, and then we'll talk about some cases down the line. Can you guys describe what you see here? I'll start with like the second year residents. I know the first years are kind of doing more medicine stuff. Can you tell me what these structures are? What is, you'll see my mouse, so what's this? Iris, right? And then what's this? Cornea. And you guys, some people have a term for this. What's that? Yeah. So that'll help guide you to the scleral spur. This little corneal wedge. So that's where things insert into the sclera. And then what's this tissue here? Ciliary body. And can someone describe what's going on here? What would you describe that as? What's that look like? If you're just going to describe it. Okay, so there's an effusion there. And if you were going to just verbalize, like, what does it look like? Is it like what's this stranding going on? Have you seen that before? So what space is that? Is that retina? Is it sclera? Suprachoroidal. So yes, the choroidal space. And these septations I want you to pay attention to, okay? Typically when you have a uveal effusion, like if you had hypotony, seen that? Does it have a septated look to it? From what you remember? We'll start showing some examples. There's going to be one critical thing I want you to pay attention to because it can help lead you to a diagnosis. So between the UBMs and OCTs, we talked about the tissue penetration. I do think some of the swept source machines, we don't have access to some of these in the US, but they are better for the angle, the general gestalt of the angle. But the view is really, really nice on a modern UBM as far as the entire angle-to-angle imaging. Now, it is ideal for imaging structures anterior to vitreous. So OCT sometimes behind the iris is not going to give you great detail. The patients usually face up. So we have them on the back. It requires an anesthetic, and you have a water bath that's usually in like a condom-like balloon that's on the eye. So when you have the patient face up and on their back, if you're looking at lens-related things, that'll mimic more about what you might see in the OR, but it might not give you exactly what you're seeing when they're sitting straight up and down. We're not going to be talking about IOL-related issues here, actually. We're going to talk more about angle closure and how UBM is helpful. But it can help detect secondary causes. So you can look behind the iris, looking at ciliary body tumors, effusions. The nice thing is it images through a cloudy cornea, and your OCT generally will start breaking down if the cornea is really, really cloudy. At the same time, you can assess lens zonule status. What I really like about it, though, is you already have them there at the scanner. You can do a B scan, especially if your view is poor, and I'll show you why that's important. So let's keep going. You guys if you just speak up, I'm not going to call on anybody. I think it'll be a little bit easier. What is this structure pointing to? And this is an OCT UBM. I'm pulling off of papers here. There is better resolution now, but what is that structure? Scleral spur. So how do you know that that's a scleral spur? Yep, and a very simplistic way to look at it is where is the cornea come to meet with that scleral component here, and it normally comes into this wedge. Where this method breaks down actually is when the angle is really close and your tissues are abutted together. But in general, you're kind of looking for that. That's a simplistic way on UBM to look at it because the resolution isn't going to be as great as anterior segment OCT. So that's the scleral spur. Now, where's trabecular meshwork from there? Superior to that by about how far, roughly? Yeah, about 500 microns. So what's an easy way? What's your internal caliper to figure out 500 microns? Thickness of the cornea, peripheral cornea, right? About a millimeter or so. So take a look, cut that in half, and you'll move up, and that'll tell you about where the TM is. So if you're assessing if the angle's closed or not, that's a simplistic way to do it. All right, so let's just identify tissues here. What's this? Cornea, sclera, ciliary body, anterior chamber, lens, exactly. And then these arrows, this is, yep. And then now we're about 500 microns up or so. So this area, TM, exactly. All right, so we got that down. Now, look at the difference between an open angle and a closed angle. You can still kind of see where these two structures meet. Sometimes I'll take a look at the corneal wedge and go back about 500 microns. The TM will usually be right at the base of the corneal wedge, but you can see here that this is closed. And in fact, it's more than just closed. This is probably PAS because things are adherent and almost pulled taut into that region. But anyway, nice job identifying that. Pupil size does matter. Yvonne Baez was involved in this years ago. But if you look at UBM, so what this is pointing to, that's referring to the TM. And this is in what adapted state versus what adapted state. Which one's light, which one's dark? Which one's this? Light, exactly, and dark adapted. Now, looking at angle closure patients, you'll have people come in and usually it can be a very asymmetric glaucoma. So that's one of the clues that someone's coming in, the pressures have been relatively normal in clinic, but things can be very highly asymmetric. Like there's secondary causes, but I would put angle closure in that differential. It's not just pigment dispersion or pseudo-X or trauma, but put angle closure in that differential. But why is it that you measure a pressure that's okay in the office? Like they obviously are having pressure issues, but why is that? Like, why do you think that is? I mean, you're taking a snapshot in clinic. It's a bright environment, so they're sitting out in the waiting room. Their pupils constricted. How about when you get them to the slit lamp? You got a light there. That's one thing. But I mean, they're accommodating the entire time. So it's a very artificial environment as to what is probably happening day to day. But you can see how much the pupil can affect things. Now, the next stuff that we're going to talk about, this isn't so important to recognize the differences in how the anatomy looks, but it's good to see the variety when you're looking at ultrasound. So again, now that we're kind of oriented with our landmarks, I'm going to show you 3 different versions of what angle closure can look like. This is a little bit more typical of plateau. So it has this pronounced angulation in the peripheral third of the iris. So the ciliary body is kind of anteriorly rotated, and that's giving a plateau component. If you compare here, you actually see that there's this bulky peripheral iris, so it's pretty large, but the iris actually angulates sharply into the middle of the ciliary body. So it's now how the iris inserts into the ciliary body that gives you this more plateau-like configuration. And if you compare here, this has a little bit of a mixture of both. It's a very large ciliary body. You can see that anterior rotation, so it's very bulky in the periphery. And you can see that the iris inserts very peripheral in the angle. The distinctions there clinically actually don't matter at all, but you're going to see a lot of variety in angle closure, so it's not always going to look the same way. Now, what I want to go through is how do you determine if you're going to do like an LPI or not? So describe this. Anyone kind of describe this? What's that look like? Is the angle open or closed, first of all? Closed. So if we go here, here's scleral spur here, right? Where these 2 lines meet. And you go about 500 microns. TM's probably somewhere around here. And what do you see underneath the iris? Actually, so you can see the lens. What do you see underneath the iris? Nothing, exactly. So there is a true sulcus space. One of the things that's useful with UBM is, would a PI have the potential to benefit you or not? And if there's not pupillary block or a true sulcus space in this area, unlikely it's going to do anything. So when you see this space, I think it's reasonable to then consider an LPI, especially in plateau iris. You might be able to decompress that and it flattens down. How about this one? Yeah, large sulcus space. And again, you have that curvature that's showing you pupillary block. I think it would be reasonable to do an LPI. How about here? Same, but what do you think is going on here? What if you had that for a 360 appearance? PAS. You see how it's kind of pulling the iris taut? Would you LPI that? Would that give you any benefit? It was 360 degrees. It might relieve pupil block, but now you already have iris plastered up against your TM, right? So there is a chance that whatever little functional TM that you have, just the pigment shed could actually decompensate that entire thing. So just be mindful of that. If you have a lot of PAS, I would be cautious about doing an LPI. What's this? Ciliary body cyst. Roughly how many people do you think you're going to see that in? 1 to 2%. It's even higher than that. Could be up to even 20% if you look for it. And would this be a cause of angle closure, like secondary angle closure? It can, exactly. Would it give you angle closure though? Without pupillary block, I would say it's extremely rare for the cysts themselves to give you an angle closure. They're generally pretty sporadic throughout the ciliary body. They're not going to be like uniform through the ciliary body. So if you see that in an angle closure patient, it's not the cyst that you're going to treat. Your pathway still generally goes with how you would treat angle closure in general. So let's go through some cases. This was a patient. She was in her 80s, had a myopic shift after cataract surgery. So I'll play this video a couple of times. Just describe what you see. How's the lens against the iris? What's that look like to you? Yeah, so it's plastered up against there. There's really actually not much of a sulcus space here, is there? No. And if you look, now what else are you looking for when you have the UBM? You have it at your disposal. We touched on it briefly on that first video. So you guys mentioned that the suprachoroidal space, right? So here, so I'll take a peek there. Do you see and what I call septations? Do you really see those? No. Okay. So here's a still. You see this patient, everything looks like it's pushed upward anteriorly. would you do an LPI here? You may not. I think you could argue both ways. Maybe a little bit of a sulcus space here. Unlikely that it's going to do anything, though. Why? That mechanism doesn't seem to be a true pupillary block. It seems like there is something posterior that's pushing anteriorly. So you don't see much in the way of effusions. This is post-phaco, a myopic shift. Like, what are you starting to think about? Malignant glaucoma, exactly. So if you have that, what would be, let's say even do the LPI, what would be something else that you would try? Yep, deepen them. So could you give them a drop? Atropine. Does that work? Yeah, and when it works, this is what it looks like. So this is pre and post atropine. Look at her pupil. Doesn't really change that much, right? She was happy. We were thinking we might have to operate, but she's actually very happy. Her angle's open, pressure normalizes, and she's fine taking atropine actually once a day. And the pupil doesn't dilate much in her, so she's not that bothered by the effects of atropine that would normally bother them. I'd say this isn't super common that you can leave someone on atropine and they're okay with it, but she was okay with it. But you can see the marked difference there just from that tensioning, pulling everything back. A little bit of a grand roundsy type of case. So this was a 55-year-old male, comes in with blurry vision. Before referral, pressures were in the 60s. They noted angle closure. It was bilateral. So is that interesting to you? Bilateral acute, subacute angle closure, is that typical? No, not typical. So you're already thinking, are you thinking a primary angle closure process? No, you should not be. Start thinking secondary. So LPIs, Diamox, pilocarpine, Simbrinza. So next day, pressures in the high 30s to 40s. They repeat the LPI. If your LPI is patent, do you think there's utility in repeating it? Does the size of the LPI matter? What is the cumulative opening of the iridolenticular channel? So the space between the iris and the lens, because fluid's moving through there, right? When you look at the slit lamp, it looks like they're always abutting, but obviously they're not. There's fluid moving through it. How big do you think that entire opening is? If you had to guess. And the reason why it's important to think about it is like, you're like, well, you know, what's the surface tension of water? How much space do I actually need for it to move through? Ballpark number in microns. 50 microns. That's exactly what it is. It's around 50 microns. So your LPI has got to be at least 50 microns to feel comfortable with it. Generally, your LPIs are probably going to be 50 microns if you can see all the way through them. So repeat LPI, probably not a great thing because you're going to make things a little bit worse. Now, upon presentation, actually comes through our emergency department, hand motion, 2400 on the other eye, mid dilated, minimal reaction, motility's full, pressure's 38 and 35, okay? So they're on 3 classes of medication, including an oral acetazolamide. So this is what it looks like. Again, like let's do one of the second years, just describe this picture. And I don't know if we can get the lights a little dimmer. Yeah, perfect. Yeah, there we go. Okay, so what's going on? It's obvious stuff. There's nothing really hidden in the picture. Yep. So corneal edema, but also with decimate folds, perfect. And then with the surrounding area is pretty, very hyperemic. What's this? Heme, why is that happening? Might be MVI. LPIs. So there's their other LPIs. So you'll get a little blood. One thing about angle closure, especially like an acute attack, I've seen patients come in with an ankle closure crisis and they have an acute attack or subacute attack and they have uveitis or inflammation. And then people will generally start jumping toward, here's a uveitic process that's now leading to their elevated pressure. Just the angle closure attack can give you inflammation. So be mindful of that. If it really looks like angle closure, the angle's closed, the other angle is maybe like a grade 0 to 1, just start being mindful. It's probably not a primary uveitic process, but this was from the LPI. So they probably do have a little bit of NS. This is the other side, a lot of injection, defolds, you have corneal edema, a couple of transillumination defects from the LPIs. And then how's your chamber? Yeah, very, very shallow, okay? So unable, you can't view any angle structures. The view is poor, you have corneal edema. What would be your way to assess what's going on? You already hinted to me that you don't like the fact that this is bilateral on presentation. UBM, that's what the talk's about, right? Their options were sending it in for maybe possible repeat LPI. We threw in the UBM, but they were actually sending in for phaco. Would that be a smart move in this case?
No.
This is very different than primary angle closure. Again, there's something else going on. So we get the UBM. Would this be a patient where you think an LPI would help? No. Do you see any sulcus space? How massive does this look? Now, and if you're used to looking at them, it's starting to have a little bit hypoechogenicity. So what does that tell you in the tissue? Or what? Yeah, so swollen, so there's fluid in there, right? So there's fluid in there. So you already have the UBM probe, and I'll tell you, like, do you guys have the ultrasound available, like on call, if you go into the ER? Yeah. Okay. You can even use the probes to measure the anterior chamber just to get a quick look, but you already have the ultrasound there. So why not look toward the back? When you see that, you actually have what are these? Choroidal effusions. What's the difference between that and like that earlier picture that I was showing you? No septations, right? So start thinking about why some things are going to have fluid in the choroid and have septations, why some won't. And it's not something that's like commonly reported, but when you start seeing it, you have to think like, why is there a difference there? And I'm still alluding to what we're going to help you out as far as diagnosis. So now what? So large serous spontaneous effusions, bilateral, it's causing angle closure. They're on medications including acetazolamide and pilocarpine. What would you start changing? And I'm going to tell you, 2 days prior, presented for shortness of breath to another emergency room, chest pain, cough, fevers, kind of like an upper respiratory infection type of thing. And they were given Symbicort and prednisone. I'm not going to dive too deep into why that can mess things up, so don't worry about the medication. But, like, what are you thinking about right now? Are there any medicine changes that you would make? Yeah, so right now, tell me your reasoning for thinking about stopping the pilocarpine.
So if you start atropine, this will open the increase the flow.
So right. So what you're doing, like we showed you before, atropine can really kind of posteriorly rotate. Pilo could be making the problem worse because it's a secondary mechanism right now. And then you can stabilize maybe the blood aqueous barrier, decrease inflammation, but you said start steroids. So there's probably an inflammatory process. Now, is it going to be local steroids versus systemic? That's to be debated. But yes, the acetazolamide, why were you thinking about stopping that? So that could potentially contribute. Now, he wasn't on it before, so I think it's reasonable to keep him on there. He got admitted at that presentation also for a GI bleed. So now he's had upper respiratory issues. He's got a GI bleed, and he's coming in around the time that all this is happening with a bilateral serous spontaneous effusion and secondary angle closure. So let's think about what causes effusions. So I have that listed up there. Let's just talk through it. So how does hypotony cause an effusion? Right. So the uveal scleral outflow is not pressure dependent, okay? But if you lower the pressure, you can actually get fluid that moves into that space. And this is where I want you to start thinking now. If I decompress the eye and fluid fills that space, where's the fluid go in the choroidal space? Is it between tissue planes? Is it in tissue planes? Is it in and between tissue planes? It's actually pretty diffuse. So now you're getting a decompressive event. It's very diffuse. That's why your serous effusions after like a trab or a tube opening don't show the septations. The septations are actually fluid shuttled in between tissue planes. And so what am I hinting at? What process will shuttle fluid in between tissue planes into the suprachoroidal space? Something that can occur after like a trauma in the anterior segment. Start thinking about that. Increased venous outflow pressure. So There are anatomical reasons why you could have this, like a Sturge-Weber type of thing. Sometimes, I mean, if you really had like a really tight band or a buckle that was shutting off vortex veins, less likely. Increased vascular permeability. So you're talking about steroid treatment. Well, this might be an inflammatory process that's actually linked to what's going on to the rest of him, right? So you have to start thinking about, do we address the inflammation? And then uveal fusion syndrome, B dump, those types of things. I call them kind of hand wavy because we don't really know the mechanism. I think it's just more of an inflammatory process that also marries with how easily fluid leaves the sclera. But medications can certainly cause it, and you alluded to that. So Topamax or Dopamax, acetazolamide, these are like the big ones to think about. In general, what do you have to do if you have a patient that comes in with like Topamax and they have angle closure secondary to it? Just stop the medication. Generally, medicines should be allowed, like if they're IOP side, you can treat that. You can consider oral treatment of steroid, even like a Medrol dose pack would not be unreasonable. And it could take several weeks, but this is not something that's going to require like surgery to go that route. Sulfas, SSRIs sometimes can cause it. So there are plenty of mechanisms, but generally, if it's an idiosyncratic reaction, it'll be at some point linked to when they started. It doesn't have to be the same day or the same week, but it can be within like a month or so after they're on the medication. So those are things to consider. So what do you do next? So we're going to address the underlying issue. So for inflammation, we already talked about steroids. Let's just assume that this patient had glaucoma surgery like a trab. What would you do if they have effusions now and they're hypotenuse from a trab? What are things that you could do?
AC fill.
Yeah, AC fill. Yep. Atropine. Say the bleb's massive or it's leaking. Surgery, sutures, tighten your sutures, a bandage contact lens. Sometimes you can start cutting down on the steroids if you're far out enough and it's still hypotenuse. So you're addressing the mechanisms. A shallow AC, we kind of alluded to here, cycloplegics to deepen the AC, rotating the ciliary body. And then surgical drainage might be appropriate if it's still flat. All your mechanisms that you've tried are not working. But in these cases with bilateral, we have to dig a little deeper. So let me talk to you about his course. You're very correct as far as kind of how to think about it. So presents here, pressures are really high. All right. So the first thing we did was stop the pilocarpine and start steroids, Q2, and atropinize. So exactly what you said. We cut down on glaucoma medications and we dilated the patient. And the next day already we're getting a response where the pressure's coming down. So pressure's coming down. So what's the next step? We're going to stop because that could be a confounder. Diamox, like you said, just in case. Unlikely because they presented before the Diamox. So we stopped the Diamox. Now just on topicals and high-dose pred and atropine, pressure's now below physiologic IOP. Why would that be?
Shutdown, maybe.
Ciliary body shutdown's one. What else is happening? The glaucoma drops, but glaucoma drops don't, if I gave them to you, unlikely you're going to be like 2s, 3s, 4s. So what happened? You saw the effusions in the back. What could be happening to the ciliary body?
Trauma, maybe.
Well, once it detaches and rotates, it's actually not as effective in pumping aqueous or producing aqueous. So if you have a choroidal effusion, sometimes you get into this spiral where now you're making less fluid and the hypotony can continue, especially post-surgical. So now we're going to start backing off on medication, but you see we're not going to back off on the pred yet. I mean, we go to like every 4 hours, but the topical drops are starting to be reduced. And the atropine probably is helping open the angle, and that's why now you're getting a pressure resolution. So vision's getting better. You start to see this is about, this is actually within the first week after starting all these therapies and removing some of them. So the cornea is improving. You're already getting less congestion around the eye. The AC is starting to deepen. It's still shallow, but starting to deepen. The choroidals are not going to resolve right away. And then, so this is pre, this is post. Some of these are bedside scans. So you can see just deepening with atropine, and you can tell that that pupil is now dilated. We've deepened the AC, and that's helping with the pressure. Now, a month later, the effusions are gone. So are you satisfied? It's done, right? There's some cause, though, and there's a chance that it could come back. And this is where I kind of like showing this presentation because when I was chief, so we have an extra year as if you're selected to run all the traumas there. So you're doing all the globes. I was on call like Monday through Thursday and then weekends, and you're the one that goes in. We have 1,400 beds in our hospital, and you're the guy that does the consults with the residents. I can tell you, especially with the like first and second years, you can really be impactful in the team. So they're working up a GI bleed, upper respiratory infection. They're going through all this. And we're starting to just kind of like now dig into case reports. Like what else causes a bilateral uveal effusion? And it was the resident that was like, hey, I think we should draw some of these labs. And it is kind of grand roundsy and more of a zebra, but this was actually his presenting sign for his HIV diagnosis. And if you look in the literature, again, there are case reports. The reasonings why it could present that way, I don't think anyone truly understands. But treating the HIV can also help with this. Now, medically, we were able to do it. I think the steroids that we were giving him did help. And initially, they kind of thought maybe it was like an upper respiratory infection, a bronchitis. And so they gave him oral steroids, which I think helped our cause. But this was his presenting sign for HIV. And there are several case reports that report this. But the choroidal space is really, really interesting. It's so hypermetabolic, and there are systemic conditions that can affect it. And that's what I want to impart on you. Bilateral subacute angle closure should really tip you off to something else going on. And I would not stop until you really get a good sense of what it is. All right, another case. So this is a year post-trauma. She was 77 years old. Very poor historian. No history of surgery. You can tell she's pseudophakic though, so that's already interesting. So very similar. I'm not going to make you describe this, but I do want you to think about, so what would I do here, right? She's coming in. I can't get a view. She is extremely difficult to examine. There's a history of a couple of falls. So you're already kind of like thinking like, what else could be going on? Again, in these cases, like when I look in the shallow, the AC looks a little bit shallow. I'm going to get a UBM. And it's extremely useful and helpful. So what do you see here? Fluid. Do you see the classic septations like what we were showing on the first picture? You don't. So pressure is actually a little low here. It could be a cleft, exactly. But I'm going to tell you why it's not, and we'll look specifically as to why it's not. So these are effusions. You don't see the septations. This is more of a hypotony-related issue. It's diffuse fluid coming into tissue planes and around tissue planes, which is why you lose the septations. So we have her at the scanner, and we also see this. I can't examine that. I can't even examine her. Like we have to crank the lid to examine her, and the gonios, you're not going to be able to see what's going on. What is this? So what tissue plane is this in? Sclera. Goes down to here. And so this is into the anterior chamber. Here's cornea. Are there classic incisions that you would make that might look like this? She had phaco, obviously, here. It's an IOL. Scleral tunnel. So scleral tunnel. Do your phaco wounds have a chunk of tissue missing? Do your phaco wounds have a chunk of iris missing? No. Confidence in your PD. I love it. I mess with mine all the time. And it ultimately comes back to you, man. That's the crazy part. So attempted chunk of tissue. It looks pretty surgical, pretty clean cut here and here. This looks very surgical. Scleral tunnel. Hypotony. Sclerotomy, PI, what? Old trab. Poor historian, doesn't know. You're getting confused with the history because she doesn't give you a good history. But this was an old trab. And so now, I mean, the time frame, like who knows? It could have been hypotenuse for a long time ago. But if I didn't have the UBM, I would not have really been able to make a diagnosis as to what the history was. You could not examine her. Like you cannot. She doesn't look down. She's kind of like looking. I mean, it was a miserable exam, which is why the UBM was so useful. So another one with questionable history, and this is where we're going to kind of highlight the difference between how the fluid looks in that suprachoroidal space. So 44-year-old, this guy was a fighter, heavy drinker, had a myopic shift. He was sent in for narrow angle despite an LPI. The pressure was 17 on outside and around there on presentation. And the referral was actually for a dislocated cataract post-trauma. So this is from that video that I showed earlier. So what do you see? How's the AC? Very shallow. And what are you seeing there in the suprachoroidal space? Septated. Angle's closed, but the pressure's normal. Does that make sense? Is it a hypotenuse reason why there's fluid in that area? Pressure's normal. So now what else could be going on, which you said earlier? Post-trauma. So ciliary shutdown is one option. Cyclodialysis cleft. And that's the distinction I want you to make. If you look at imaging here, when you have fluid shuttling from the, and it's not 100% universal, but just a huge tip-off. If you're looking and you're trying to determine like what is causing my shallowing and this fluid in the space, if it's kind of diffuse fluid, think about your serous effusions, they're not septated. If fluid's getting shuttled from the anterior chamber into that supraciliary space, it's moving around the tissue planes of the choroid. And that's why you get those septations. And this clues you into, this is not a dislocated cataract. It could look like it though. If you see this here, you know how shallow the AC is. He's post-trauma. Zonules could be a mess, and that's why he's angle closed. But the pressure's normal, and now you're getting septations, and that should clue you into cyclodialysis cleft. This is where UBM actually shines. You can't see the cleft on gonioscopy. What are some methods that you could view it in the office if you don't have UBM, if you're suspecting it? Gonio, but the angle's closed. B-scan probably isn't going to give you the resolution to detect where the clefts are, especially small. And I'll show you why. There have been, I mean, it's stuff that's reported. You can inject viscoelastic hyper deep in the AC to give yourself an angle view and then start looking for the cleft. So that's one thing that you can do. So you can inject viscoelastic. Now, it depends on what the pressure is doing and how comfortable you feel. But I think UBM is critical here. So these are the septations. You'll see this in post-trauma. You'll see fluid in the choroid. Everything's now pushed anteriorly because there's fluid shuttled into the supraciliary space. And in this case, it doesn't leave through the sclera as well. So it stays in that region. You have maybe like 150, 200 microns of fluid that will move everything anteriorly and cause a shallow AC. And that's all coming from the anterior chamber. So I actually showed you where the cleft was in the video. And it's on one cut. That's the cleft. It can be so small sometimes, and it's really difficult to see. And on gonioscopy, now, if you could deepen the AC, you would generally be able to view this. But this is where UBM shines in angle closure, is really in post-traumatic clefts, post-surgical clefts, identifying a cyclodialysis cleft. And just to give you a little bit of like a hint, so, you know, the CyPass device that was recalled, this is fluid around the CyPass device. And I had to use these pictures because it was old school from my fellowship. Again, kind of homage to the Toronto area, but you see these septations here. That fluid is getting shuttled from the anterior chamber into the supraciliary space. It's moving through between the septations, so you see distinct tissue planes versus fluid that fills that tissue plane, and it really kind of neutralizes the look of the anatomy here. And even in the literature, this is, again, something that's used to identify supraciliary clefts. So that was what I had for our talk. I am more than happy to answer questions, like talk about cases. I really do appreciate you guys being so interactive with me going through some of these. Was that useful? Okay, good deal. Again, thank you. I know we'll have like a session with just the residents alone. To those of you virtually listening out there, obviously have friends here. Really, really thankful for the mentors that have kind of guided me through this process. And so I really appreciate the chance to give you a talk. Thank you. Yeah.
So go back to the first case,
Uh-huh.
the patient has edema, and then the ciliary flush, high IOP,
Yeah.
also GID.
Uh-huh.
My differential include CC fistula.
Okay.
So it usually comes to later in the diagnosis.
Mm-hmm. Mm-hmm.
GID
Mm.
don't scan.
Right.
So was that included in the diagnosis?
We thought about it, but for it to be subacute and bilateral without trauma. So generally, if you have like low flow fistulas, you won't get that diffuse hyperemia. It'll be areas where like those episcleral vessels are more enlarged. So the diffuse hyperemia probably tilts you more toward, it's more of like an inflammatory process, or could have even just been the LPIs, right, that they had. The high flow fistulas, on the other hand, post-trauma, sure, you can get those. It has a different look to it. You should then generally see maybe more blood in Schlemm's canal. It's unlikely to cause like an effusive process. The GI bleed could also have been like a red herring, right? But it was the upper respiratory infection, the GI bleed, what was going on in the total inflammatory process that guided us more that route than someone who had like chronic diabetes, a vasculopath that might have a low flow fistula versus trauma and like a high flow fistula.
Thank you for the talk. And just a question, maybe like it's a bit deviated from the topic, but for patients that you know that they're prone to have severe cardiac infusion surgery, and then if you're planning cataract surgery to them, like severe cardiac infusion can significantly affect the lens position. Do you still aim them plano or you aim them a bit transoptic?
Yeah, so in order. Yes, for sure. So the question is about changing your like what you're thinking about effusions and effective lens position. There are patients that have a higher propensity to have effusions post cataract surgery. Do we change our target or adjust our lens power? I would actually tell you no. If you're worried about that process, there was a randomized study out of Southeast Asia, and average axial lengths were around like 18, so small eyes. They randomized one group to phaco alone. The other group, because that's a high-risk population of effusion, the other group was randomized to a single scleral window or sclerotomy. And essentially what they found was 4 effusions in the phaco-only side and no effusions on the side that had a prophylactic scleral window. And I would say if you're worried about it, that's the route you should take. It does reduce the chance of kind of this posterior pressure feeling that you might get. A lot of it in those cases is permeability of the aqueous through the ciliary body, but leaving the sclera. So the sclera is generally thicker, and that's why they end up getting effusions post-phaco. And if you open that area and leave it, sometimes I'll take like a Kelly punch after we do it. It allows fluid to extravasate through there. Yeah, but I wouldn't change my IOL power because I'm still hoping to get a normal effective lens position. I don't want to adjust my lens anticipating there might be an angle closure episode because I'm probably going to want to treat that anyway. So treat the primary process that would cause the angle closure. That'll also get your lens to drop back.
Related question from the virtual audience. Let's suppose you have a post-cataract patient with malignant glaucoma and you atropinize them. How long do you atropinize them, and how do you get them off the atropine? If they, they do dilate well and symptomatic enough.
Yeah, you should see the effect of the atropine fairly immediately. Like if you put them on there in a day or two, I mean, you should see things rotating back if it's going to take effect. And if it doesn't, I mean, your next steps are determining like why. Like axial length measurements are going to be pretty critical. And some people just get them. We had a routine post-phaco patient not long ago that had shallowing of the AC, a little bit of a myopic shift, but pressure really started to climb. They were a prior angle closure patient. And to atropinize them, we do it, but it's unlikely you're going to be able to leave them on there. So now you're looking at other methods, whether you're making scleral windows or making a unicameral eye. So going through the iris, large PI, through capsule, breaking up anterior hyaloid, fairly decent vitrectomy in that region so you don't get vitreous blocking that PI again. But atropine should work fairly quick. It's just not a great long-term solution though. And if it doesn't work, you'll know within a few days.
In that situation, you try it like a laserizer, please?
You can. I think the PI's got to be pretty large. And to get a really big PI, because the vitreous can really obstruct it, either you've had to have a large surgical PI ahead of time, but to just start with like laser to make the PI, I think it's pretty painful for patients. But the ones that are at risk, sometimes we'll make a PI in the OR with like a vitrector and make it pretty big. And we have a family, their axial lengths are in the 14s as adults. And there are several of them. And really like the post-phacos, even doing ICHV in the OR, 2 of them have obstructed. And so we went through multiple laser rounds in the office and actually were able to break the attacks, but the PI has to be big. And I don't think you can start de novo with like a PI with the laser to get it big enough. It's so painful. You shed so much pigment, there's a risk of bleeding. Get the PI first, but then that allows you to do laser through the capsule and the anterior hyaloid.
And for the second line, would you reactively give atropine to give diamonds before the second step?
I think it's reasonable to decompress the eye as much as possible. So like an oral CAI, I mean, mannitol if you really wanted to. I don't use mannitol, but I think it's an okay consideration. You still need to address why. So the atropine doesn't address the issue where the fluid's not leaving through sclera. Atropine's kind of like sweeping the problem under the rug, so to speak. So in that lady who was atropinized and she deepened, sure, she deepened symptomatically, she was resolved, but that's not addressing the issue, which is too much fluid in the choroidal space that's not leaving through sclera. So generally, like scleral windows help, or if you do an IZHV and have a unicameral eye, that would help.
A question for the residents. Who invented UBM and where?
Oh, I don't know this.
They should know this.
Oh, they should know this. That's it.
Yeah, so Chuck Pavlin.
Uh-huh.
I-9.
I love that.
And he invented UBM. So this is, Canada's contribution to.
That's a great contribution.
Exposure. And actually, that study you highlighted.
With Yvonne. Yeah.
Chuck is one of the co-authors, as well as Alan Slomovic.
Mhm.
Today, he's got a question. Well, with that, I'll defer to Alan, but we should be proud that UBM has made such an impact on ophthalmology and was invented right here in Toronto by one of our ophthalmologists, Chuck Pavlin.
That's fantastic.
Over to
Very
Alan.
cool.
Alan, go ahead.
Okay, thank you. So first of all, fantastic talk. It really.
He's talking, it says up here, but
Can you hear me?
I can hear you now through my computer.
Okay, so first of all, fantastic talk. It really very nicely illustrated with all those beautiful UBM shots. So as a cornea surgeon, we do, a fair amount of DMEC here. And at the end of the operation, we fill the eye with air.
Mm-hmm.
Pupils are of varying size. Could you comment on what you think is the ideal size of a PI? Usually we either, to make matters worse, we won't only put air in, but many times we'll put in like 20% or 18% of SF6, which is isoexpansol. So what size, is it still a 50 micron diameter PI or roughly that to try to avoid getting into problems with pupil block?
Yeah, the pupil block, unfortunately, like that air liquid interface, that surface tension, you can get a pretty large bubble that will not move through the PI. I would even argue, there's a chance like you might not be able to make a PI large enough unless it's egregiously large in order to break it. Just a side shoot from what you're discussing though, one of the things I've seen post-corneal surgery is the sometimes decompression of the eye and then the intraoperative hardening. And have you ever had that before, where the eye does not deepen like during your DMEC surgery or DOLC?
Well, what can happen is if the bubble gets behind the pupil.
Right, it can do that. And then the other thing is the decompression though. So there are reports like in the middle of these surgeries where they get this rock hard eye, the eye does not deepen at all. And I think some of that is more of an intraop malignant type of picture. But in order to get the PI large enough to allow gas to move through, it generally would have to be pretty big since it's the gas within liquid layer.
I agree. And that's one of the things that has not been commented about in the literature. And I was concerned about the surface tension between air and the aqueous. We the PI is not done temporally or superiorly as you would for prophylaxis for a angle closure. It's usually done inferiorly with the hope that when they get up, let's say to eat something or go to the washroom, that will equalize things out. Right. So maybe the idea is you want to leave an 80%, not 100% air bubble. So hopefully that leaves a fluid aqueous interface, or rather an aqueous interface where there's not so much surface tension preventing movement.
Yeah, exactly. So you have just pure liquid moving through that inferior PI instead of the air. I agree with you. I don't know if you can make a PI large enough without it being too large.
Thank you. Great talk.
Thanks so much.
We've got a question or comment from Matt Schlenker as well.
Yeah.
Hey, Arsham, great job. Thank you. As Amandeep said, you're basically teaching the city who invented UBM how to do UBM.
Right.
So, but you are teaching. And for those who don't know, he was a fantastic fellow here. When I was a PGY4, he was the fellow, and I was like, I want to do what this guy's doing. So he really inspired me to go into glaucoma and to do the fellowship I did. So I'm indebted to Arsham.
Wow. Too nice.
Arsham, what I want to talk to you about, you just showed a bunch of cases where an LPI was possibly not helpful. Mm-hmm. So, we've had in our city, we've had many patients with close to 360 PAS LPI'd, maybe closed the deal. We've had many NVG cases, LPI'd. We've had malignant glaucoma, LPI'd. We've had patients who've been LPI'd and there was so much inflammation after, like you said, the angle closure is probably contributing, but the LPI wasn't probably helping either. Flaccid temporal iris, post-LPI, and patients really traumatized by the LPI experience and weary to have more definitive treatment after when they get sent to me. So I'm at the point in my practice, and in my advice to the residents is no more LPIs for acute angle closure, as in never. Maybe I'm being extreme here.
Yeah.
Diamox almost always breaks the attack, and then an LPI and maybe, or I'm sorry, AC paracentesis in maybe 10 to 20% of cases that you can't get down medically. And then going to lens-based surgery.
Yep.
Am I being too extreme with our residents? What are your thoughts?
I don't think so. So a couple of things for us. The LPI minimum number for residency graduation is now becoming harder and harder to hit, partly because it's reserved in some of these more extreme cases. You can break the pupil block without an LPI, like things that you talked about. One is actually just getting the pressure down. You could relieve the pressure of the iris against the lens. AC paracentesis does that. You get a sudden shift in the fluid dynamics and you could burp fluid through, and now you break the block. And LPIs, like, you really have to be able to gonio and tell that you don't have PAS, and it's hard for you to know if there's PAS or not. And so I generally like to see, like, hey, I can have like an area where I can really deepen the angle before we do it. In an acute angle closure episode, I think what's scary for the residents, and this is the only thing where I would say I feel for them when you tell them this, is like an AC tap might be really, really tricky when the whole thing is shallow and they're phakic. But sometimes compressive gonioscopy, and I'm talking about, the pressure's 60. You gotta fight more than 60 when you push on the eye in order to try to break it. I think that's reasonable. But medical therapy is pretty paramount to try to get that pressure down, and the AC tap really helps your medicines work. And then you get a better view. Now you can actually gonio and see if they have PAS or not, and then move toward the LPI. So maybe I'd say, like, for NVG, I don't think it has a great role at all. PAS, it really has no role in my mind when it's 360. If it's a primary acute angle closure attack, I think there is value to that. Just make sure that they don't have PAS, get the corneal view clear, wait, and even start steroids. Like what Matt's referring to is, it's hard to do an LPI when the iris is edematous and foggy. And that will traumatize the patient. It's extremely painful in an already inflamed eye. So one thing I would add is just treat them with steroids to try to cool off the inflammation. And if you get a better angle view, I think the prophylaxis of the LPI is probably better sometimes than breaking the attack.
Yeah, thank you. And we do hear the concern about the AC paracentesis. And, my response is, if you start the Rexus, we will finish it when we do the phaco. We're putting the patient on steroids. And again, your goal is the long-term for this patient. So that's what I say when I get asked that question. I recognize, for everyone, Arshan laid it out. There's basically three types of angle closure for simplicity, the lens rise, plateau, and pupil block. And of course, if a uveitic comes in with like serious pupil block, which is more like iris Bombay, well, that's different. The treatment, sometimes you can push and you can blow through the posterior synechii and actually break it with the compression. But yeah, an LPI can be amazing. But if it's like a lot of lens rise, yes, the AC paracentesis is hard, but your LPI is not gonna, not gonna do much anyway. And then plateau, we all know it's not gonna do much. So, well, thank you. You're making me feel better about my recommendation. And again, residents, if call me, call Irfan, call someone. If you're thinking you need to do an LPI and you want someone to say, no, it's okay, just break the attack.
Matt, for those cases that are inflamed, poor corneal vision, a lot of corneal edema, pressure's way up there. I've never had to do a cataract in those situations. I actually reviewed a paper that was talking about it for one of the journals. Have you ever is it extremely difficult to do that cataract under those circumstances? Also, you're not going to get much pupil dilation either. Any comments about cataract?
Yeah, surgery? I mean, Arsha may have more than me, but I would say you need to wait a little while. I think generally the eyes settle down. And yep, the pupil's not going to dilate well. It's probably going to be worse after you do the LPI, after you've traumatized it. So you're going to be dealing with small pupil phaco in a difficult eye. And yeah, the view is not going to be great. But this is, you know, this is glaucoma, and that's what the patient needs in the long term. I've never had one so bad that I couldn't do the phaco. We can use an endoscope for illumination sometimes when the cornea is not very good. You can, you know, Dr. Curtis knows very well the tricks of taking off the epithelium to sometimes help as well if it's a microcystic problem. But just letting the eye settle down on Diamox, in my experience, does a lot. And I'm just saying, when you do the LPI, that process is going to be longer.
Yeah, I agree. I think the highest risk ones are the ones that are high pressure. Like 5FU studies show that in TRAB, like your delta between like a high pressure to a low pressure is the most risky. And I'm with Matt. I mean, for angle closure eyes going into phaco, you try to do everything you can to get the pressure down before you operate. Because one of the few eyes that I've lost on the table just during routine surgery was in this type of a case, medicated like crazy, LPI, I mean, everything. And very high pressure angle closure would go in, and toward the end of the case, she has a suprachoroidal hemorrhage, despite everything we try to do to keep the AC and the pressure maintained. All right, thanks everybody.
Well, thank you, Arsham. I think those were fantastic rounds. And as I said to you guys earlier, he's clearly thought about things in ways that many people haven't. And actually, Matt Schlenker is one of those people too. So if you're responsible for us having Matt Schlenker as a glaucoma surgeon, that we thank you, because he's a gift to this.
He doesn't realize I look up to him. So,
so it's a mutual admiration society, right? Arsham, thank you very much. I thought those rounds were fantastic. With a little
thank
token of
you.
appreciation
Thank
from
you
the
so
University of
much.
Toronto.
Thank you.
And UBM, guys, it's a Canadian or Toronto
Cool.
contribution. So you know, it's been around for maybe 30, 40 years, and it still contributes to our specialty. So shout out to Dr. Pavlin, may he rest in peace, but his contributions live on. Thank you, guys. I'll see you guys next week for rounds.
Perfect. Thank you. Thanks so
you.
much.
Oh, I'm sorry.
nice.
I'm sorry. All right. I'm sorry.
Oh,
That's
yeah.
right. We have no, thank you,
you're not
Sandra. No rounds next week in lieu of AAO, so we'll see you in a couple weeks. Thank you.
All right.
Bye.
You guys want to do like stretch break? Because I know we got some other stuff we can talk about.